posture assessments, supplementary information. Okay, so we're going to be looking at our various postural deficiencies that we've gone through, and we're just going to be looking at really the muscle's origins in the insertions and how they relate to posture. It's always a good tool to use the fibre orientation or the arrangement of these muscle fibres, remembering muscles can only pull in their respective straight lines or their lines of pull. So to determine some of these tights and weak, it's just really a question of tracing back the length or the decreased length of these fibres. So starting with elevated shoulder, which is characterized by one shoulder being higher than the other. Muscles that could be short and tight could be the trapezius, the upper trapezius that is. As we can see, they attach from the base of the skull. Some of these spinous projections or spinous processes, and they attach to the spine of the scapula in itself. Now they at rest could be tight, and therefore lifting or elevating the shoulder girdle or the scapula up. This could be contributed by another shoulder elevator or a scapular elevator called the levator scapula, which again will work with upper traps to elevate the scapula. So upper trapezius and levator scapula can be our two short and tight muscles. Moving down, as a result of levator scapula and upper trapezius lifting up the scapula, it would elongate whatever happens to be attached to the medial aspect of it. And in this case, middle lower traps, which you can see they would be stretched, as would lower trapezius, along with rhomboids. They would be long and weak. Now we can improve this condition by stretching upper trapezius and levator scapula, and encouraging the activation of rhomboids, middle and lower trapezius, which can be done on a lat pull down, so we can focus on that depression and that medial rotation squeeze point, so really to encourage that squeeze of a lat pull down. Protracted scapula, which is often a symptom of kyphosis, which is an exaggerated thoracic curve, often with the weight of the head being forward of the plumb line, along with the weight of the shoulders being in front due to tight pecs, serratus anterior, and maybe anterior delts. The weight of the shoulders and the head can increase the curve of the thoracic region, inducing what is known as kyphosis, which is an exaggerated thoracic curve. So protracted scapula can all be protracted by our large shoulder flexor, horizontal flexor, and adductor, along with the medial humeral rotator, that is the muscle pec major, has many actions. It can be contributed by its smaller pec minor, which lies underneath, and then serratus anterior can also play a role in the shoulders or the scapula being forward. As a result, it's simply taken the antagonistic muscles with it, so it's lengthened the opposing muscles. So we're looking at middle traps and lower trapezius, along with rhomboids, would all be elongated and stretched. And we can improve this by again stretching our tight muscles, our tight pec major, pec minor, and encourage the activation of middle, lower traps and rhomboids, which is just a case of encouraging that squeezing phase of a row. So we either do a scapular shrug or a cable row shrug, where you're just inducing scapular retraction, or you can integrate that into a stretch, pull, squeeze movement, but really focusing the squeezing phase. Okay, internally rotated shoulders. So internal or medially rotated shoulders can be a symptom of kyphosis or can be a precursor to kyphosis. Often we'll distinguish or determine medial shoulder rotation by having the elbow positioned in the lateral position towards us. So as reviewing this individual from the lateral aspect, we might note his elbow sticking outwards, and the elbow should be facing backwards. Another way to determine whether the shoulder is medially rotated is from the posterior view. So viewing the client from the back, we might see their palms of their hands facing towards us, which is obviously not how it's meant to be. The palms of the hands should be facing slightly medially anteriorly. Okay, muscles that could be causing this medially rotated shoulder could be pectoralis major, subscapularis, which is a very powerful medial rotator because it's very close to the joint, And we could throw in our other medial rotators being lat dorsi, teres major, along with the anterior deltoid. And just as you can see by the fiber orientation of lat dorsi, it traverses along the inside of the humerus, attaches to the front of the humerus, but by virtue of it attaching via the medial aspect of the humerus, it pulls the humerus medially or rotates the shoulder medially, as does teres major. So your long weeks are simply the external rotator muscles, and in this case it happens to be the fibers of the posterior deltoid, the fibers of infraspinatus, and the fibers of teres minor. All three are external rotators and are subsequently long and weak in this postural condition. Okay, we can improve this by stretching pecs and lats and by encouraging the activation of our weak external rotators. As we can see here, this gentleman is doing a cable adducted external rotation exercise, and this man is doing a reverse fly on a machine to encourage posterior deltoid and middle and lower trap activation. Okay, looking at an anterior pelvic tilt, which often is associated with lumbar lordosis, so an increase in lumbar lordotic curve. The anterior pelvic tilt is characterized by the ASIS, the anterior superior iliac spine, the bony projection at the front of the pelvis, being significantly lower than its PSIS counterpart, its posterior superior iliac spine at the back. So this back spinal landmark or iliac spinal landmark should be higher significantly than the front. About 3/4 of an inch for females, or about 1/2 an inch difference in males. Now there should be a natural anterior tilt there. That natural anterior tilt gives rise to the natural lumbar curve, which is how we want it to be, but if it's too anteriorly tilted, we could have too much of a lumbar lordotic curve there, which can compromise spinal integrity. Now this can be due to the tightness of the iliopsoas group, which we can see here, constitutes iliacus, which is a muscle which just takes up the underside of the ilium, and psoas major and minor. All three muscles attached to the lesser trochanter of the femur, or the medial aspect of the femur. They are, as you can see, pulling simply down, and we can see rectus femoris, which is also a hip flexor, can pull down, as could sartorius and tensor fasciae latae. All will contribute to that anterior pelvic tilt. This is accompanied by force pulling upwards on the opposite side, or on the back side, and this upward pull is due to predominantly quadratus lumborum, a muscle that originates from the posterior 2/3 of the iliac crest, as we see there. This is the back 2/3, and the transverse processes to L1 to L5, as we can see along here, and plonks itself on the 12th rib. So this, when tight, can cause the pelvis to tilt anteriorly. Mix it up with a bit of a rectus spinae contracting together, and we will throw in a bit of multifidus, which is a deeper muscle of the erector spinae group. All can contribute to an excessively tilted pelvis anteriorly. The long and weak ones are very simply the muscles of the anterior abdominal wall, and as we see the pubic crest, which is just this ridge on the pubis, as that moves away from the ribs, it will elongate whichever is attached to that surface, and this happens to be rectus abdominis and internal and external obliques. At the back, we've got the ischial bones moving away from the lower legs, elongating the length of hamstrings, so biceps femoris, a muscle that's mainly tendon, and a muscle that's mainly membrane, so membranosus. And then glute max, as we can see, the sacrum and the ilia will move away from the femur, and that would increase the length of the fibers of glute max. Ways to improve this is to simply stretch the hip flexors with a hip flexor stretch, stretch the lower back with obviously a lower back stretch and maybe a rectus femoris stretch, as we can see there, and encourage the activation of the glutes, glute max, by doing a supine bridge, or the anterior abdominal wall muscles, and by maintaining spinal neutrality or neutral spine, that will encourage the activation of this. Okay, a posterior tilt, which is going the other way now, which is simply where the PSIS and the ASIS are heading towards being level. So there isn't the height difference that we would like. and they may be towards level. What this might do is diminish or decrease the lumbar curve, giving the appearance of a flat back, so an absent or reduced lumbar lordosis. This can be due to the tightness of the rectus abdominis, along with the obliques pulling up. At the back, we can have a tightness of the hamstrings and the glutes pulling down. This would, as we can see if we trace that fibre of glutes downwards, it would cause the pelvis to tilt backwards, which is obviously called a posterior tilt. As a result, it can elongate the hip flexors, so we can see iliopsoas, rectus femoris can all be elongated in length, as can sartorius and the tensor fasciae latae. We can also see an increase in muscle length of the erector spinae group and the quadratus lumborum. We can improve this by stretching the abdominal wall, stretching the glutes, and we maybe can do some knee raises for the hip flexors. We would also want to be mindful of over-activating the rec abs, which are already prone to activation in this postural condition. Okay, a hip hike or a pelvic hike simply is the lateral spinal flexors being tight on one side. So erector spinae, quadratus lumborum, and the obliques on one side. That would be the opposite, the weak muscles on the opposite side being lengthened. So tight ES, QL, and obliques. Opposite would be the same but weak. And we would simply stretch and maybe do a side plank on the lowered side. Stretch the higher side and the lower side. Okay, a lateral hip shift, which is where the body is shifted to one side. Usually there's a hyperextended knee on the weight-bearing leg, and as they squat, we might see this if we did a movement pattern test as their body shifting to one side. Now, this shift is due to a weakness or a deficiency in the femoral stabilizers, so the muscles that stabilize the head of the femur, and these muscles are glute medius and minimus. Now, they can be elongated and loose, and we simply encourage those muscles to be stretched with strengthening, and we can encourage it with some hip abduction